So we are going to talk about autoimmune hepatitis, which is also known as plasma cell hepatitis or leukoid hepatitis. So the first question is, which of the following histological findings are seen in autoimmune hepatitis? So it is actually all of the following histological findings can be seen in a patient with autoimmune hepatitis. First is empiriopoiesis. So what is empiriopoiesis? Anyone? In empiriopoiesis, there is active penetration of one cell into the another cell. But the cell which is engulfing another cell will not destroy that cell. Okay. So this is what we call as empiriopoiesis. So in empiriopoiesis, one cell is ingesting another cell, but the cell which is being phagocytosed, that is actually intact. Okay. In contrast to phagocytosis, in phagocytosis, the cell which is ingested, it is being degraded by the bigger cell. Okay. So in empiriopoiesis, one cell, it gets penetrated into the another cell and it remains intact there. While in phagocytosis, the cell which is being ingested by the bigger cell is degraded by that cell. Okay. So empiriopoiesis, classical example is autoimmune hepatitis. Apart from that, it can also be seen in Rosai-Dorfman disease. So what is Rosai-Dorfman disease? It's a kind of lymphadenopathy. You have massive lymphadenopathy in cervical region, and once you do the histology, you will find this phenomena of empiriopoiesis. Okay. Lymphoplasmacytic infiltration. This is again classical of autoimmune hepatitis. Also in IgG4 related disease. In IgG4 related disease also we have lymphoplasmacytic infiltration, but it rarely affects your liver parenchyma. Okay. While in autoimmune hepatitis, we have lymphoplasmacytic infiltration. Interface hepatitis or piecemeal necrosis. So interface hepatitis is once we talk about the portal tract. So we have inflammatory infiltrate around the portal tract. While if we talk about the SLE hepatitis, in SLE hepatitis, the inflammatory infiltration is in the whole of the lobule. Okay. In a patient with autoimmune hepatitis, it is only around the portal tract, which is called as interface hepatitis. While in lupus hepatitis, the infiltration is in the lobule. So it is a lobular kind of hepatitis. Another important difference between autoimmune hepatitis and lupus hepatitis is in autoimmune hepatitis, we have marked lymphoplasmacytic infiltration, while in lupus hepatitis, there is paucity of lymphoid infiltrates. There is paucity of lymphoid infiltrates. So these are two important distinguishing points. Then rosates. Rosate formation can very well be seen in patients with autoimmune hepatitis and centrilobular necrosis. Particularly, we have an acute presentation. In that cases, we can have this centrilobular necrosis. So all of the following histological findings are important, but the most important is interface hepatitis, or otherwise called as piecemeal necrosis, in which the inflammatory infiltration is in the around the portal tract. Okay, and it is mainly a lymphoplasmacytic infiltration. Okay. You can have rosates, you can have empiriopoiesis, which is active penetration of one cell into the other cell, and the cell remains intact. Okay, and in acute presentation, you can have centrilobular necrosis. Bridging necrosis and multi-acinar necrosis, they are indicative of severe inflammatory activity. Okay, so the red mark, interface hepatitis, plasma cell infiltration, rosates, and empiriopoiesis, they are the hallmark of autoimmune hepatitis. Now, what is this phenomenon called as? I have already told you, this is empiriopoiesis, in which one cell is getting penetrated into another cell, which is the larger one. And this smaller cell, it remains intact within the larger cell. So this is called as empiriopoiesis, which is classically seen in autoimmune hepatitis and Rosai-Dorfman disease. While in phagocytosis, a smaller cell, once it is phagocytosed by the larger cell, it is degraded by the larger cell. Okay, that is phagocytosis. What is TART cell? TART cell is a monocyte is actually ingesting a nuclei. Okay, monocyte is ingesting a non-lysed nuclei. That is called as a TART cell. And in LE cell, monocyte or macrophage, that is ingesting a denatured nuclear material of another cell. So in LE cell, we have the denatured nuclear material inside monocyte or macrophage. So this is important. Okay. Now, which of the following are seen in autoimmune hepatitis? You can mark your answers. What do you expect in autoimmune hepatitis among the following? Okay. So Tanvi thinks that it is all of the above. Actually, when we talk about the autoimmune hepatitis, the most common presentation, 30% of patients can be asymptomatic. Okay, they can be asymptomatic. The most common symptom would be easy fatigability. Okay, it would be easy fatigability, and most common physical finding would be hepatomegaly. The most common symptom would be easy fatigability. Pruritus, it is uncommon in autoimmune hepatitis. If somebody has pruritus, you should rather think of primary biliary cirrhosis, right? You should think of primary biliary cirrhosis. Similarly, hyperpigmentation. Hyperpigmentation is again seen in primary biliary cirrhosis. Okay, so pruritus, hyperpigmentation, and what else? The xanthelasma. The xanthelasma and xanthomas, all of them are actually seen in primary biliary cirrhosis, not in your so pruritus, hyperpigmentation, and xanthelasma, they are seen in primary biliary cirrhosis. Weight loss, again, weight loss is not seen in autoimmune hepatitis. If you have significant weight loss, you would rather think of primary sclerosing cholangitis. Jaundice can be seen in advanced cases of autoimmune hepatitis. So easy fatigability and jaundice, they can be seen in autoimmune hepatitis, but if you have pruritus or hyperpigmentation, you should rather think of primary biliary cirrhosis. And weight loss, it is a pointer to primary sclerosing cholangitis. Okay. Yes, Nikhil, you are correct. It is easy fatigability. Now, all of the following statements are true about concurrent autoimmune diseases in autoimmune hepatitis, except, so celiac disease, it is seen in 3% of cases, right? Celiac disease is found in 3% of cases. Thyroid disorders and rheumatoid arthritis are most common. So this is actually a true statement. So if a patient of you have a patient of autoimmune hepatitis, you must get TFT done to rule out associated Hashimoto thyroiditis or Graves' disease, and they can have rheumatoid arthritis in a fair percentage of cases, right? Young patients, they commonly have autoimmune hepatitis and ulcerative colitis. So it is very frequent to have concomitant autoimmune hepatitis and autoimmune hemolytic anemia, particularly in young patients. And in older patients, you have more of rheumatic illnesses and thyroid disorders. So actually none of the others. So all of the statements are correct, right? So in 3% of patients of autoimmune hepatitis, you can have celiac sprue. In young patients, you should screen for autoimmune hemolytic anemia and ulcerative colitis. In elderly, you should screen for thyroid disorders and rheumatic illnesses. Okay. Now, this is the clinical features I was talking about, that pruritus, hyperpigmentation, and weight loss if present should point to an alternative diagnosis because they are virtually absent in a patient with autoimmune hepatitis. The most common symptom is fatigability. The most common finding is hepatomegaly. Jaundice, it can be seen in severe disease. So if you find a patient of autoimmune hepatitis who's presenting with jaundice, that means it is already an advanced case. You can have 30% of patients can be asymptomatic. You can have concurrent autoimmune diseases, most common being autoimmune thyroiditis, Graves' disease, and rheumatoid arthritis. Okay. In young patients, we have autoimmune hemolytic anemia and ulcerative colitis. In elderly, we have thyroid disorders and rheumatic conditions. Now, which of the following is not compatible with possibility of autoimmune hepatitis? So in autoimmune hepatitis, the SGOT-PT, they can range from 100 to 1000. Okay. So this is true. Bilirubin, it can be elevated in advanced cases of autoimmune hepatitis, but ALP, it is near normal. Okay. Alkaline phosphatase, it is near normal, or it is only modestly elevated. If you have marked elevation of alkaline phosphatase in a patient with autoimmune hepatitis, you will call it as overlap syndrome. Okay. So in 10% of autoimmune hepatitis patient, you can have overlap syndrome. In that case, you will have markedly elevated ALP. Otherwise, in autoimmune hepatitis per se, you have only modest elevation of alkaline phosphatase, right? Albumin, it can fall in advanced disease, and prothrombin time also gets prolonged in advanced disease. So the only incorrect option is alkaline phosphatase. So in a patient with autoimmune hepatitis, alkaline phosphatase tends to remain normal, okay, in majority of cases. And SGOT-PT, it ranges from 100 to 1000. So in severe cases, bilirubin can rise up to 10 milligram per deciliter. ALP is near normal or moderately elevated. If you have marked elevation, you should think of concomitant primary biliary cirrhosis. In advanced disease, you can have jaundice, hypoalbuminemia, and coagulopathy. Okay. Apart from that, polyclonal hypergamma-globulinemia, right? So if your gamma globulin is more than 2.5 gram per deciliter, so it is one of the pointer to a autoimmune hepatitis, right? But mind you, in alcoholic liver disease, there can be elevation of IgA levels. In primary biliary cirrhosis, there is elevation of IgM levels, right? And here again, you can have hypergamma-globulin. Rheumatoid factor can also be positive. Now, all of the following antibodies are seen in type 1 autoimmune hepatitis except. So you can mark this answer. So you can have anti-actin antibodies, you can have anti-soluble liver antigen. So initially we used to say type 1, type 2 and type 3 autoimmune hepatitis, but now we have only two types, type 1 and type 2. In type 1 only, we have a subset of patients who have this antibody, anti-SLA antibodies. And those patients have a poor prognosis. So you can have SLA antibody in type 1 autoimmune hepatitis. Liver cytosol 1 antibodies and LKM1 antibodies are actually present in type 2 autoimmune hepatitis, right? Rest all can be seen in patients with type 1 autoimmune hepatitis, anti-actin, anti-soluble liver antigen, anti-smooth muscle antigen, and atypical P-ANG. Okay, so we have two types of autoimmune hepatitis. Type 1, which is usually seen in young women, and type 2 is seen in children. In type 1, we have the classic hyperglobulinemia, ANA positivity. So ANA positivity is seen in 100% of cases of type 1 autoimmune hepatitis. Okay, so we have three conditions in which there is 100% ANA positivity. One of them is type 1 autoimmune hepatitis. What are the other two? What are the other two conditions in which ANA is positive in 100% apart from type 1 autoimmune hepatitis?
Mixed connective tissue disease.
Yes, one is drug-induced lupus, another is mixed connective tissue disorder. Very good. So these are the three conditions in which ANA positivity is seen in 100% of cases. Fine. Apart from that, in type 1 autoimmune hepatitis, you can have anti-actin antibody, anti-smooth muscle antigen antibody. You can have atypical P-ANCA. So P-ANCA is very non-specific. It can be seen in the typical P-ANCA you see in small vessel vasculitis. Atypical P-ANCA can be seen in autoimmune hepatitis. It can be seen in primary sclerosing cholangitis. It can be seen in ulcerative colitis. It can be seen in Behçet's disease. It can be seen in Cogan syndrome, right? So you have so many conditions where you can have atypical P-ANCA. So whenever you go for ANCA testing, you should always do it by ELISA. Okay, because doing it with immunofluorescence may not lead you to a definitive diagnosis. Okay. So we have a subset of type 1 autoimmune hepatitis in which patients lack ANA and anti-LKM1, but they have antibodies to soluble liver antigen. They are associated with poorer prognosis. Okay, so initially this subset of patient was categorized as type 3 autoimmune hepatitis, but now they are included in type 1 autoimmune hepatitis itself. Okay, in type 2 autoimmune hepatitis, we have ANA negative and we have anti-liver kidney microsomal antibody 1 and anti-liver cytosol 1 antibody, right? So you should remember these antibodies. In type 1, we have ANA, actin, SMA, and P-ANCA and SLA. In type 2, we have anti-LKM1 and anti-liver cytosol 1 antibody. Okay. Now, which of the following is not included in simplified scoring system for diagnosis of autoimmune hepatitis? So we have a simplified scoring system for diagnosis of autoimmune hepatitis, and it actually does not include predominant aminotransferase elevation. Okay, rest are included in the simplified scoring system. So in simplified scoring system, we have autoantibodies. ANA or SMA if positive, we give it a score of +1. ANA or SMA if positive in a titer of more than equal to 1:80, we give it a score of +2. And anti-LKM1 more than equal to 1:80, we give it +2 score. Anti-SLA if positive, no matter how much is the titer, if it is positive, we give it a score of +2, right? Immunoglobulin, if it is more than upper limit of normal, we score it as +1. If it is more than 1.1 times upper limit of normal, we give it a score of +2. Okay. Histological findings, if they are compatible with autoimmune hepatitis, you give it +1. But if you have the typical findings of lymphoplasmacytic infiltration and interface hepatitis, you score it as +2, right? Absence of viral hepatitis, we give it as +2 score. And so these are four important things: autoantibodies, immunoglobulin, histology findings, and absence of viral hepatitis. So if the score is more than equal to 7, we have the definitive diagnosis. If it is 6, we have a probable diagnosis of autoimmune hepatitis. All right. Now, all of the following are defining features of severe autoimmune hepatitis except. So if your AST is more than equal to 10 times upper limit of normal, you have it is severe autoimmune hepatitis. If ALT is more than equal to 5 times upper limit of normal and gamma globulin is more than 2 times upper limit of normal, again, it portends poor prognosis, right? Bridging necrosis or multilobular collapse, that is again pointed to severe autoimmune hepatitis. And if the patient is symptomatic because of the autoimmune hepatitis, it is always a severe autoimmune hepatitis, right? Failure of bilirubin to improve after 2 weeks of therapy. So this is once you start the patient of autoimmune hepatitis on treatment, right? And if the bilirubin, it fails to improve after 2 weeks, that means the patient is a candidate for liver transplantation, but it is not the criteria for severe autoimmune hepatitis. So severe autoimmune hepatitis is if AST is more than 10 times upper limit of normal, or if ALT is more than 5 times, but serum globulin is more than 2 times normal, if you have bridging necrosis or multilobular collapse on histology, or if patient is symptomatic, right? 6-month mortality rate of severe autoimmune hepatitis patients who are untreated is up to 40%, and severe autoimmune hepatitis is an indication for immediate therapy. So according to the Schlesinger, all patients of autoimmune hepatitis has to be treated, be it mild, moderate, severe, but patients who have severe, you have indication for immediate therapy. In mild cases, you can wait for some time, okay? So these are the clues to autoimmune hepatitis. If the patient has a female gender, if there is a predominant transaminitis, if there is hyperglobulinemia, if you have antibody positivity to ANA, SMA, or LKM1, if patient has concurrent autoimmune hemolytic anemia or other autoimmune diseases, if histology is showing you interface hepatitis or plasma cells, and if this condition is responsive to glucocorticoids, so all of them are pointers to autoimmune hepatitis. What goes against autoimmune hepatitis is predominant alkaline phosphatase elevation, because that will make you think of primary biliary cirrhosis or primary sclerosing cholangitis more. If you have anti-mitochondrial antibody positivity, again, you will think of primary biliary cirrhosis. If viral markers are positive, or if there is a history of hepatotoxic drug intake, or if histology is showing bile duct injury, fatty infiltration, iron overload, or viral inclusions, right? So suggestive of alternative causes of liver pathology, right? Now, which of the following treatment is not true in respect to treatment of autoimmune hepatitis? So if I go by Harrison, so the first statement is incorrect, but as per Schlesinger, all patients with autoimmune hepatitis, they are candidates for therapy, right? But it is only the urgency of treatment which is being decided by the grade of autoimmune hepatitis. If it is severe, you will go for immediate therapy. If it is mild, you can wait for some time. But eventually, all patients will require treatment. Prednisone plus azathioprine combination therapy is preferred over prednisolone alone therapy in acute severe fulminant autoimmune hepatitis. So this is actually not true, right? This is actually not true. In fulminant cases, prednisone alone therapy is preferred over the combination therapy, okay? And likelihood of relapse following therapy is at least 50%. That's why at times you have to give it lifelong therapy, right? Because the relapse rate is very high once you taper the treatment. Refractory autoimmune hepatitis is treated with high-dose glucocorticoid or glucocorticoid plus high-dose azathioprine. So you have to treat refractory cases with 1 mg per kg per day dose of glucocorticoids, right? Failure of bilirubin to improve after 2 weeks of therapy is an indication for liver transplantation. So all patients with AIH are candidates for therapy. Urgency is the only variable in making decision to treat. This is as per Schlesinger. And in Harrison, they mentioned that therapy is not indicated for mild or asymptomatic forms. So this is one contention. Now, treatment of AIH, first line is prednisolone 30 mg daily. You taper it over a 4-week period to 10 mg daily. You give 30 mg for 1 week, then 20 mg for 1 week, then 15 mg for 2 weeks. And eventually you continue on 10 mg dose, right? Plus azathioprine 50 mg daily. So this is combination therapy of prednisone plus azathioprine, or you can give prednisolone alone therapy. So in prednisolone alone therapy, you have to give it at a dose of 1 mg per kg per day. Okay. So 60 mg daily, you taper it to 20 mg daily over 40 weeks, right? So this is a higher dose therapy. So this is prednisolone alone therapy. Now, disadvantages of prednisolone alone therapy is definitely you have higher risk of glucocorticoid side effects, but it is indicated in patients who are pregnant, because azathioprine is not very safe in pregnant patients. So you would rather go for prednisone alone therapy. If severe cytopenias are there, again, you will prefer prednisone alone therapy. If patient has absent thiopurine methyltransferase activity, okay, so azathioprine is being metabolized by this enzyme, and if patient has absent TPMT activity, those patients are at high risk of developing neutropenia and bone marrow suppression. So again, you will go for prednisone alone therapy. If patient has azathioprine intolerance, or if patient has active malignancy, because azathioprine being an immunosuppressant, always there is a risk of malignancy. So if in a patient who have active malignancy, again, you will go for prednisone alone therapy. And in fulminant cases, you will go for prednisone alone therapy, right? So TPMT activity, ideally before starting azathioprine in any patient, we should go for TPMT activity. But because there is usually a financial constraint, okay, affordability issue, so you can look for the MCV. If MCV is more than 100, so you should not start the azathioprine in such patients. So it is a surrogate marker. If mean corpuscular volume is more than 100, you should not start on azathioprine. You should rather go for prednisone alone therapy. Okay. Now there is an emerging role of budesonide plus azathioprine as the first line treatment in non-cirrhotic patients. Mind you, in non-cirrhotic treatment naive patients with uncomplicated autoimmune hepatitis, you have no features of liver failure, right? So if patients are non-cirrhotic and if it is uncomplicated autoimmune hepatitis, you can give budesonide plus azathioprine, particularly in patients who are obese, diabetes, hypertensive, or who are at risk of osteoporosis. You can prefer this regimen because giving prednisone will further worsen these conditions. Okay. Now, how much should be the duration of therapy? At least you should give maintenance therapy for 12 to 18 months. But as the relapse rate is more than equal to 50%, some majority of patients, they require indefinite therapy. So indefinitely, you have to put such patients on azathioprine 2 mg per kg daily, or you can give low dose prednisone therapy less than equal to 10 mg daily. Okay. Now, treatment of refractory autoimmune hepatitis, high dose glucocorticoid, 1 mg per kg per day. Okay, 1 mg per kg per day. You taper it after 1 month. For 1 month, you will continue with 160 mg dose only. After 1 month, you will start tapering, right? Or you can give glucocorticoid plus high dose azathioprine. So high dose azathioprine in 150 mg daily. So you can choose either of them, right? So high dose glucocorticoid or glucocorticoid plus high dose azathioprine. And third line therapy are cyclosporine, tacrolimus, mycophenolate, mofetil, infliximab, and rituximab. Okay. Now this is as per the Schlesinger response to first line therapy. So again, it is a repetition. If patient has a remission means patient is asymptomatic, aminotransferases as normalized, liver histology as normalized, then you can actually you can discontinue the therapy, right? If patient has sustained remission, and if patient relapse, then you can start azathioprine or low dose prednisone. If there is a treatment failure, that means if there is worsening of aminotransferase or worsening of clinical status or worsening of liver histology, you will start on high dose glucocorticoid therapy or other salvage therapy, right? So what is the role of liver transplantation? So if a patient has a failure of medical therapy, you will start that patient, you will consider that patient for liver transplantation. If there is a development of decompensated liver cirrhosis, that means the patient has developed ascites, hepatic encephalopathy, or coagulopathy, or upper GI bleed, in such patient, you will enlist those patients for liver transplantation. And if there is a failure of bilirubin to improve after 2 weeks of therapy in severe autoimmune hepatitis, so it is the very important pointer that this patient is a candidate for liver transplantation. Now, the poor prognostic signs are if again the bilirubin is not improving after 2 weeks of therapy, or if you have multilobular collapse at the presentation, right, on histology. So it is a poor prognostic sign. Now, which of the following is not true at drug-induced autoimmune hepatitis? Actually, the most commonly implicated drugs are minocycline and nitrofurantoin, and it is more common in women. Okay, so most of the autoimmune conditions, they are more common in women. Acute onset is typical. Yeah, you have acute onset of disease after exposure to the culprit drug. Recurrence is usually not seen, right? And you can have portal neutrophils and intercellular cholestasis. In classical autoimmune hepatitis, we have lymphoplasmacytic infiltration. But in drug-induced autoimmune hepatitis, you can have neutrophils, right? In classical autoimmune hepatitis, you do not have cholestasis, but here you can have cholestasis, okay? Now, the drug-induced autoimmune hepatitis, most common culprit drugs are minocycline and nitrofurantoin, a disease of women. You have acute onset of jaundice. You can have portal neutrophils and intracellular cholestasis, right? In classical autoimmune hepatitis, jaundice is seen in advanced cases, right? But here you can have early onset of jaundice. Cirrhosis is rare and usually it resolves after discontinuation of the drug. If required, you can give a short course of glucocorticoids and it does not recur. Okay. Now, all of the following are causes of microvesicular steatosis except. So the answer is actually hemochromatosis, because in hemochromatosis, we have macrovascular steatosis. Rest are the classical causes of microvascular steatosis. So in acute fatty liver of pregnancy or HELP syndrome, we have microvesicular steatosis. And in drug-induced liver injury, particularly with ART, valproic acid or tetracyclines, you have again microvesicular steatosis. In hypervitaminosis A, vitamin A toxicity, you have microvascular steatosis, a Reyes syndrome, and Legionella infection. So we have so many conditions which can lead to macrovascular steatosis, but very few conditions which can lead to microvascular steatosis. So acute fatty liver of pregnancy, drug-induced liver injury, Reyes syndrome, and Legionella. So these are 4 important conditions which you should remember, which can lead to microvesicular steatosis. Now, anti-LCM antibodies, anti-LCM1 antibody is seen in autoimmune hepatitis and chronic hepatitis C. So LCM1 antibody is actually seen in autoimmune hepatitis type 2. So LCM1 is seen in type 2 autoimmune hepatitis, also in chronic hepatitis C. LCM2 antibodies are seen in drug-induced hepatitis, and LCM3 antibodies are seen in chronic hepatitis D. Okay. So this is all from my side. If you have any doubt, you can ask me.